Right, welcome back. We're going to be talking now about complications that you may encounter in the course of conduction system pacing. Of course, as with all device implants, you can have these complications, which I will not go into, but there are some complications which are specific to conduction system pacing, and in particular, left bundle branch pacing, that are related to the route taken by the lead as it traverses into the ventricular septum. This table is taken from the ERA consensus statement on the conduction system pacing. And you can see that some of the common complications that you might encounter are septal perforation, right bundle branch block, and so forth. And there are also some late complications that may occur sometime later after the procedure. I think the one that is probably most worrying and most common would be septal perforation, which has been cited as occurring with a frequency of up to 14% in this particular table. But that might be a bit of an overestimate because the Milo study, which was a large European study looking at left bundle branch pacing in Europe, showed that the occurrence of perforation of the lead into the LV cavity was something like under 4% rather than 14%. And some of the other complications that can occur with left bundle branch pacing are also fairly uncommon, I would say, by looking at the percentage of occurrences in this table. I mentioned right bundle branch injury, and this can occur because of manipulation of the sheath and lead while pace mapping on the right side of the septum, or because of passage of the lead through the right bundle branch itself when advancing the helix and the lead through the septum. So some of the ways that we can avoid this is to intentionally look out for it. And if you happen to see a right bundle branch potential on your pacing lead while you are mapping in sinus rhythm, then you would want to avoid that area because you don't want to skewer your lead through the right bundle branch. AV block can also occur during lead implantation, either transiently because of manipulation, or if you happen to cause some sort of injury to the His bundle or AV node while manipulating the sheath. But most of the time, this is temporary because you are not actually physically putting an instrument or a lead through the AV node or His bundle when you perform left bundle branch pacing. But nonetheless, it is good to have a backup pacing lead, as I mentioned in my earlier talk, if you are patients who have transient heart block or who are likely to develop complete heart block while you are doing this kind of manipulation. For example, someone with pre-existing left bundle branch block, and you might accidentally knock the right bundle and you get complete heart block during the process. This is an interesting kind of case where we're attempting to pace map for a suitable starting point on the septum. And after passing the sheath into the RV and extending the lead, we found that we could not capture the ventricular septum. And it doesn't appear obvious why at the outset from the RAO projection, but in the LAO projection, it becomes clear that the sheath has entered into the coronary sinus and into one of the left-sided coronary veins, and therefore, you can't capture because the lead is just floating in the CS. So it is important to look in two views, not just in RAO, but also LAO to see the orientation of your lead and your sheath. I wanted to cover some of the complications which are specific to extendable helix leads, bearing in mind that when you use an extendable helix lead for the purpose of left bundle branch pacing, we really have to convert or prepare the lead in such a way that it becomes functionally like a fixed helix lead. And if we do not do this, ahead of time, it will not be possible to advance the lead into the septum by rotating the lead body. So I've talked about this in my earlier talk, but it bears repetition that the adjustable helix has to first be extended, and then the screw mechanism has to be pre-tensioned to allow the whole lead and helix to move as one unit when you rotate the lead body. So I showed this in my earlier talk as well, that if you do not do this pre-tensioning maneuver, your helix gets retracted into the housing when you rotate the lead body. But if you prepare the lead beforehand by pre-tensioning the system, then you'll be able to rotate the lead body, and that would move the helix along with it and allow you to penetrate the septum easily. So this is an important thing to do. And the damage to the helix is another issue that we come across during the process of implantation. It is important to make sure that the lead and the sheath are oriented perpendicular to the septum so that the helix can penetrate into the septum easily and not at an angle. Because if you do not ensure that the sheath and lead are perpendicular, the tangential approach of the helix tends to cause damage to the helix and render the lead non-usable. If you persist in trying to advance the entire lead after damage has occurred to the helix, this can happen. The helix gets deformed, and when you try to retract the lead can unravel and result in an outcome like this. Or worse still, the helix gets trapped within the myocardium and the entire system cannot be disengaged. You can see what's happening here, where an attempt to pull the whole system back results in the helix breaking off and getting retained in the ventricular myocardium. In this particular case, the broken helix was left within the myocardium because attempts to retrieve it were not successful. And we elected to just go to default, leave, put a lead at the RV apex and move on. If an attempt is made to pull back on the lead after the helix has become trapped within the myocardium, the lead may unravel, as you can see in this diagram here, because the components just come apart when you pull. And so in a situation where the lead helix is stuck in the myocardium, I would recommend that we use a locking stylet to ensure that the components stay in as a unit without unraveling when you pull back on the lead. These are further pictures to show what actually happened when an attempt was made to pull the lead out without a locking stylet. There are other times when we've managed to extract the broken helix from the myocardium, from the ventricular septum, by using a multi-loop snare and a deflectable sheath. But this is something that we want to try and avoid in the first place. So there are a few things that can happen when you rotate the lead body with the helix extended. One of the things that can happen on the left side is entanglement, where you do not actually penetrate into the muscle of the septum. You just kind of catch a few fibers or even the chordae from the tricuspid valve, and you just entangle everything in your helix. And eventually, there's no progress because the helix is all filled up with tissue and it's not able to bite into the myocardium. And when you pull back, you just see all this tissue that's stuck in there. The second thing that can happen is what the consensus statement has described as a drill effect, where in effect, rotation of the lead body and with the helix extended results in coring a hole in the myocardium without securing the lead. So it's like making a cavity, but the lead doesn't stay because there's nothing to hold it there. And this, of course, will result in dislodgement. What we want to achieve is what the paper has described as a screwdriver effect, where you are able to penetrate into the myocardium, and with the progress of the lead, the helix still holds the entire lead in place in the myocardium, but without going too far to the extent that you cause a perforation. So if the initial attempt at lead deployment is not successful, the lead should be retracted and removed from the sheath and checked for any damage to the helix, as well as to remove any tissue that may be retained within the helix. Because obviously, if you have tissue stuck within the helix, the screw is not going to bite or hold on to the tissue that it encounters subsequently in further attempts. I've also showed this earlier in my first talk that the cyto brush, which is used for pap smears, is a very useful way to clean the helix free of tissue if you have a lot of tissue that's stuck in there. And this is able to do so with no trauma significantly anyway to the lead tip. In this case report, you can see that a fracture occurred between the ring electrode and the helix of an extendable helix lead that was used for left bundle branch pacing. And the problem here was that the operator did not advance the lead deep enough into the septum, and this resulted in a hinge point that occurred between the helix and the ring electrode. And so this constant movement and bending eventually resulted in a fracture between these two poles. So obviously the way to prevent this is to ensure that your lead is advanced deep enough so that the ring electrode is in contact with the ventricular septum. The usual position of the helix tip is right under the endocardium, and this is fairly close but not perforating into the LV cavity. We will worry about perforation if we see one of these parameters. If there's a example is if there's a sudden drop in the impedance by more than 200 ohms, if the R wave height suddenly decreases, if there's a change in the current of injury where the current of injury becomes lower than half of the R wave height on the intracardiac recording, or even if the current of injury becomes a negative deflection rather than a positive deflection, you will suddenly lose capture of the left bundle branch or the myocardium. So if perforation occurs into the LV cavity, all that needs to be done is to withdraw the lead, clean it, go to a different spot, and go again. So we would want to avoid the temptation to just pull back partially and leave it in the middle of the septum, hoping that it will stay there. That's not going to happen because the lead will just move in and out of the channel that we've created. So the markers on the leads help us. It bears mention, repeat mention that, from the start of the helix to the end of the helix is 1.8 millimeters, and from the start of the helix to the start of the ring is 11.8 millimeters. So again, the ideal depth of the lead should be from the tip all the way to the start of the ring, where the ring is in contact with the right side of the septum. So you shouldn't go very much deeper than that, bearing in mind that the usual septal width is about there. It's about 12 millimeters or so. So what happens when you have a septal perforation is obviously that you see on injection of contrast that your lead has gone in too far to the other side, right, across. And the current of injury can give you some clue. So this is a paper by Dr. Ponusamy, who showed that with perforation of the lead across the septum into the LV cavity, you can get a negative kind of QRS deflection with a negative current of injury, or you can just simply have a drop in the current of injury towards the baseline. that's less than 50% of the height of the R wave, right, as compared to a case where there is no perforation at the top. Another useful parameter that he found was the unipolar impedance. So if the unipolar impedance during pacing was less than 450 ohms, that usually pointed to a perforation. A fistula into the coronary veins can also occur if the lead goes too deep or inadvertently enters into one of the coronary veins. So you can see from here that, first of all, the lead has gone too far. It's definitely in the LV cavity. And with the injection of contrast, you see a filling up of the anterior interventricular vein. And that contrast then hits into the coronary sinus. So as scary as it might look, this is usually benign. And all that needs to be done is to withdraw the lead, clean the lead, and go somewhere else. Most of the time, nothing bad happens as a result. There are, however, instances where things go a lot worse than what we've described. And this is a case report showing a massive septal hematoma after an attempt at left bundle branch pacing. So obviously, what happened here was that the lead skewered one of the septal perforators that come from the LAD probably, and the bleeding resulted in a huge hematoma that thankfully resolved on its own subsequently. A coronary artery fistula can also be formed if your lead happens to get into one of the septal perforators, the arteries, and then you get a flow that comes from there into the RV cavity. There were also case reports of ST elevation, and you can see that the ST elevation occurred in the inferior leads, which means that probably the operator had implanted the lead too far towards the inferior wall and probably occluded or damaged one of the perforators that come through from the posterior descending artery. So it's important to be mindful of the vascular anatomy and to know that we really want to aim for this sweet spot here that is in segments 4, 5, 7, 8, but below a line that joins from the his to the apex of the RV. So this is a safe zone where you are likely to be able to capture the left bundle branch, but at the same time, you would avoid most of the vessels that supply the ventricular septum. Some late complications can also occur, the most common of which is loss of capture of the conduction system. And this can be due to micro dislodgement or macro dislodgement. In left bundle branch pacing, it is not so common that we see a threshold rise, but it can still happen from scarring that occurs during the healing phase. And late septal perforation has also been described, although we haven't seen it in our center, but there are cases where following successful placement of the lead in the desired position at the left bundle branch, there's subsequent migration of the lead through the septum and into the cavity of the LV. So those are some of the complications that can occur. Fortunately, these are usually mild complications, and the more serious complications are pretty rare. So with that, I conclude my talk, and all the best for your journey for conduction system pacing.